I'm delighted on behalf of the Global Reach Committee and my co-chair, Simon Ung, to welcome you to this symposium, where we will be discussing data from 6 studies collected by surgeons from all across the world. While you settle, we're just going to play a short video, which is a welcome from some of our partner presidents. Could you play the video, please?
Hello, friends and colleagues from around the world. My name is Simon Ng, and I'm the president of the Hong Kong Society for Coloproctology. Hong Kong Society for Coloproctology is one of the founding member societies of the Global Reach Committee of the European Society of Coloproctology. And I was elected.
Could you increase the volume a little, please? Thank you.
The aim of the Global Reach Committee is to promote international collaboration between ESCP and other colorectal societies worldwide in research and education. Several international multi-center research projects, for example, the East of Damascus study and the EAGLE study in the field of coloproctology, were initiated or supported by the Global Reach Committee, with Hong Kong Society for Coloproctology playing an active role in the organization. The Hong Kong Society for Coloproctology is very delighted and honored to be part of this global community of colorectal surgeons. We strongly believe that with concerted efforts, the member societies of the Global Reach Committee can conduct meaningful research with power and impact that can alter clinical practice and benefit all the patients around the world.
My name is Cristian Perrufino. I am the president of Bolivian Society of Coloproctology. The mission that joined us between the Bolivian Society of Coloproctology and the ESCP is to advance the science, innovation, and the art of colorectal surgery through education, research, and international collaboration. Joining ESCP offers many benefits for the surgeons in any stage of their career. One of them, access to cutting-edge knowledge, continued education, scholarship, and global networking. The collaboration between the Bolivian Society of Coloproctology and the ESCP can offer benefits for both health professionals and patients. Among the most relevant, exchange of knowledge and experience, training and continued education, research, scientific publication, and improved patient care.
Hi, my name is Felipe Belulio, and I am the former president of the Chilean Society of Colon and Rectal Surgeons. I had the pleasure to work with the ESCP for a few years now, and I really think that the collaboration between societies like a Chilean society and the ESCP has created a lot of value for us in terms of getting connections with people around the globe that are top of the line.
Thank you very much.
Fields,
we can start the symposium now. Stop the video. Thank you. Could we have the first slide, please? Excellent. It's a huge pleasure to welcome you to this symposium. And on behalf of my co-chair, Professor Simon Ung, and myself, we are delighted to celebrate the Global Reach Committee. This has been formed gradually over the last 2 years, and we have membership from all across the world. And this membership actually represents the colorectal societies across all of those countries. These are the current members of the Global Reach Committee, and it is on behalf of them that we are presenting the data today. We have 6 different studies to present to you, so we have much to discuss, so you do not need to listen to me, and I'm going to hand over to my co-chair, Simon. Welcome, everyone.
Thank you very much, Dion, and once again, I would like to welcome all of you, including participants online, to join this Global Reach Symposium. Now, in the first session of today's symposium, we're going to listen to the final results of 3 important studies, either initiated or supported by the Global Reach Committee. Now, these impactful research will inform our clinical practice at a global level. Now, but before we listen to the lectures, I would like to invite 3 panel members to join the podium. So we will have a panel discussion after the 3 lectures. So the first panel member that I would like to invite to come to the stage is Dr. Felipe Belulio, President of the Chilean Society of Coloproctology. So thank you, Felipe. The second panel member is Dr. Olivo Oliveira, President of the Brazilian Society of Coloproctology. Thank you, Olivo. And the third panel member will be Nurashim Haron, President of Malaysian Society of Colorectal Surgeons. Thank you very much. So you can see we have a really international panel, all right, of discussion. Now, without further ado, I would like to invite the first speaker, all right, it's Dr. Elizabeth Lee, who is an assistant professor at the University of Birmingham. And she is going to tell us EAGLE-2 results and update on real-world rollout. Thank you, Lizzie.
Thank you for the introduction and your attention today. So I'll be presenting the final results of EAGLE-2, a global cohort study evaluating a complex intervention aimed at reducing anastomotic leak after right hemicolectomy. I have no conflicts of interest to declare. So a little background on EAGLE-1. This was a cluster randomized trial looking at a complex intervention. And this intervention was based on 3 key pillars: a web-based educational module that educated surgeons and trainees on anastomotic technique, introducing also the preoperative risk stratification calculator and in-theatre checklist. And what we were trying to establish is that if we can use this one level away, stepped up intervention to engage with surgeons, but then measure the actual patient clinical outcomes after. So picture this, it is 2019-2020, COVID has just started, and this is a trial that we struggle to keep going. However, it has very little risk factors, and we managed to deliver this throughout the whole pandemic and finish recruiting as well. After this study was concluded, we wanted to evaluate the real-world impact of what the intervention meant and what this was across the globe. So we used a cohort study with consecutive eligible cases for 8 weeks, so a snapshot audit with 30-day follow-up, looking at the same interventions. The operating surgeon completing the online training modules was what we used as the primary intervention that we measured the outcome measure from. But we also looked at the preoperative risk stratification calculator and also completing the safe anastomosis checklist, which is very much like the WHO checklist we do in theatres, but this is done before the anastomosis. And this data was collected last year from June to September. What we were able to achieve was excellent, in fact, global engagement across 60 countries and collected data on almost 3,000 patients. We also were able to achieve more than 10,000 unique visits from surgeons and trainees across the world. We also, looking at the hospital distribution, attained a very good divide between the global north and the global south. And looking at major risk factors for anastomotic leak, the column on the third from the right shows that our operating surgeons that did not complete the online training modules versus those that did, when looking at these patient factors, they were fairly similar. So overall, we had just over 300 anastomotic leaks and pelvic collections. So this equated to 10.6%. And looking at anastomotic leak alone, overall, this was 6.2%. And this reflects what we saw previously in our ESCP audits as well. And the slightly uncomfortable truth is that we do still have quite high anastomotic leaks across the world, and this is an issue that we want to continue tackling. We found that just over 22%, so 1 in 5 of the patients entered, had an operating surgeon that did not complete the modules, and the rest, over 2,000 patients, had an operating surgeon that did complete the modules. We found that those patients who had a surgeon that did not complete the modules had an anastomotic leak or pelvic collection of 16% and an anastomotic leak of just under 10%. But those who did had an anastomotic leak or pelvic collection of 9% and an anastomotic leak rate of 5.5%. So we also looked at other key critical outcomes as well that we would be interested in, such as post-operative critical care admission, that is unplanned, reoperation as well, readmission and mortality. And all of these figures in unadjusted analysis demonstrated that there was a positive signal and finding for doing the EAGLE safe anastomosis modules. When this data was split between elective and emergency, this is when we managed to tease out, that the majority of the higher leak rates, as expected, were the emergency patients. And this represented almost a quarter of the patients that were operated on by surgeons that did not complete the modules. And when we did adjusted analysis, this forest plot shows at the very top is the adjusted analysis and the odds ratio of completing the EAGLE modules and the adjusted factors. And furthermore, we also looked at the in-theatre checklist as well and showed that this was significantly, this had a significant impact on post-operative anastomotic leak as well. So what does this really mean? Anecdotal discussion with some of my colleagues, especially those from resource-limited settings, showed that especially in rural surgery, especially in areas of the world that does have very limited resources, uncertainty over energy, uncertainty over equipment as well, this simple and effective intervention was particularly helpful and useful for those. Colleagues also said that they use this to train their trainees and use this for medical students as well. So this represented a evidence-based, established way to be able to educate the surgical community at large. And we have made this open access so that anyone across the world can still use this, and we update this with new information also. In this environment where the genomics and the genotype of cancer is changing so much, and also the landscape of surgery is changing, I feel that this simple intervention can potentially still make a very strong difference. Thank you very much for your attention.
Thank you very much, Lizzie. So please come here and join the podium first. So we will have a panel discussion after the 3 talks, okay? So now we move on to the next speaker. It's Dr. Nicholas Avellaneda, colorectal surgeon from CMIC University Hospital, Argentina, who is also a member of the Global Reach Committee. So he's going to talk about LATAM, results and next plan. So thank you very much, Nico.
Good afternoon to everyone. Thank you very much for being here. As Simon said, I'm going to present the results of the Latam-Urg study, which is an audit of indications and outcomes of urgent abdominal procedures in Latin America. So this is probably the most important slide of this presentation. These are the guys who are actually behind this work and all the work that we have been doing in Latin America, the guys who put in the patients, the guys who designed the studies and everything. Therefore, I am representing this group of people. And as I said, as an introduction, we've been going around in Latin America with this type of initiatives for some time now, maybe 3 years. As you can see, there are many studies which have already been published, and some of them are still going. And I think these initiatives are very important because we have been working a lot, and of course, one slide does not resume all the work that it takes to create all these manuscripts. Well, so about this study, the first thing I should acknowledge that this crazy idea was not our idea. This idea was from Dion Morton, one of the chairs of the Global Reach Committee, and this was designed two years ago. Well, now we have the results. About the study, well, of course, when we do these type of initiatives, we always hypothesize that we always use guidelines from countries that actually don't represent our reality. Therefore, we feel that we need to create our own evidence to guide our practice. And the particular objective of this study was to assess the indications, approaches, and outcomes of urgent abdominal procedures in centers located within Latin America. The sample size calculation was done in 960 patients. This was an observational, prospective, multicentric study, and each participating center was actually recruiting for 6 weeks, and they followed the patient for 30 days during recruitment, after which they finished their participation in the study. And the primary outcome was 30-day mortality. These are actually the students from my hospital that have been working in the promotion of the study, doing usernames and everything, so our recognition to them. And about the results, we recruited 1,015 patients from 14 countries and 89 centers after the inclusion criteria. The top recruiter country was Argentina, and some of the countries within Latin America were underrepresented, like Panama, Guatemala, and Nicaragua. Oh, who put this slide? We are in France. We cannot put this. And also, Felipe is there, and Chile is not in the World Cup again. No, this is not acceptable. Sorry. So going back to the results, so we recruited 1,015 patients, and of those patients, 12% died within 30 days of the procedure. The mean age was 58 years old, and the patients who died were older. High-volume centers had less mortality than those of low volume. The patients who died had a higher Charlson comorbidity score and also a SOFA score, which was higher. Preoperative anemia was more common in patients that died, and the most common indications were bowel obstruction and bowel perforation. Some of the patients were operated without being seen by a surgeon before going to the OR, and we can see that most common involved segments of the bowel was the small bowel and the colon. Regarding the intraoperative information, ASA score was higher in patients that died, open surgery was more frequent in patients that died, and also the conversion from minimal invasive surgery to open. The intestinal resection was performed in 30% of the patients, and this was more performed in patients that died. And 191 patients received a bowel anastomosis, and Hansun anastomosis was most frequent in patients that died. The lead surgeon was not different within those who died and didn't die, but there was something very interesting that we found, which is that even though in the OR you commonly had a general surgery specialist or a subspecialist, but scrubbed in the surgery, almost 50% of the patients had only a resident and not a well-trained surgeon. And this, I think, is a really important information. Regarding the postoperative information, 42% of the patients had complications. The anastomotic leak was higher in patients that died. The reparation rate was also higher in patients that died. The prolonged ICU for patients that died was also higher, and the readmissions were the same for both groups. And to finish, the information related to mortality, as I said, the mortality associated to this procedure was 12.6%. One-third of those deaths occurred within 24 hours of the original procedure, and the most common causes of death were refractory sepsis, cardiac failure, pneumonia, and pulmonary embolism. The independent predictors in multivariate analysis for 30-day mortality was age, Charlson comorbidity index higher than 3, SOFA score higher than 3, and open surgery, which was not statistically significant anyway. So to conclude, This is, I think, the first time that in Latin America we have prospective information of high quality related to this type of procedures. The mortality was 12.6%. There seems to be a benefit of being operated in high volume centers. The most common indications were bowel obstruction, perforations located in small bowel. A high number of procedures only had a resident scrub gene for the surgery, and open surgery need for conversion to from minimally invasive surgery to open surgery, intestinal resections, and hand anastomosis were also more frequent in patients that died. And the postoperative complications of operations and anastomotic leak were also more frequent in the group of patients that died after the procedure. This has been submitted to the Lancet Americas, and we already received minor comments, so I expect this will be published within 2 months. And there are a lot of studies coming from Latin America, conducted by different surgeons from the region, so this is an exciting time for us. And we would like to thank the European Society of Coloproctology and all the advisors, international and local, that have helped us to produce this high-quality manuscript. And last but not least, here goes my deep recognition to this guy. This email was the last email we received from him. He has always been collaborating with us to understand how things are done with collaborative research, and we learned everything we know about this guy, from this guy. This email was sent 1 month before he died, so this represents a lot to us. And so wherever you are, man, I think we learned the lesson, and it's good that you didn't send me to buy a dictionary for English. Thank you very much.
So thank you very much. Thank you very much, Nicholas. Congratulations on the completion of a wonderful study from Latin America. So yeah, please join the podium. So now I'm going to introduce the next speaker, Dr. Surendra Mantu, President of the Society of Colorectal Surgeons of Singapore, also a member of the Global Reach Committee. So he will tell us about the results of east of Damascus, in particular the long-term follow-up data. So thank you very much, Surendra.
Thank you, Simon. Good afternoon. I'm presenting this study on behalf of Global Reach Committee, which is a subcommittee of ESCP. I have no disclosures, except I want to bring you greetings from the East of Damascus Study Group, our Society of Colorectal Surgeons of Singapore, and my hospital, which is located in north of Singapore. East of Damascus is based on the same protocol as Damascus study. It is a study initiated by Global Reach Committee and is coordinated via the Birmingham Surgical Trials Consortium. We had over 30 countries and 70 sites which were included in this study, and these were some of the top recruiting countries who contributed patients for this study. This is the data management, how we conducted this study. Patients were diagnosed with diverticulitis either based on the CT scan or the emergency surgery, and the data was captured in the REDCap database system, and the data which was captured on index admission was the baseline characteristics and index management, and 30-day outcomes and 6-month outcomes. We started to recruit 1,500 patients, and we managed to recruit, barring some patients, we had a data completion rate of more than 95%. And we analyzed the data into the overall cohort, which included all the patients, and we also divided the patients into region-wise cohorts based on the patients which were recruited from these regions, and they were mainly Asia, New Zealand, Australia, South America, and rest of the world. And we also analyzed patients who had right versus left-sided diverticulitis. Now, this is the overall patient demographics of this study. It's a very busy slides, but the key highlights of this table are that majority of the patients were Caucasians, 29% Asians, male-female ratio was equal, And majority of the patients, surprisingly, were non-smokers, with a median BMI of 26, and majority of the patients had good baseline health at presentation. These are the disease factors when we compare the data in terms of the region-wise cohorts. And again, the key highlights, in Asians, the right-sided diverticulitis was present in nearly 50% of patients, and rest of the cohorts, including Europe, left-sided disease was present in nearly 90% of the patients. So that means even in Europe and rest of the Western countries, we do see right-sided diverticulitis in 10% of patients. And on presentation, the disease was more severe in the patients who were recruited from the European cohort. These are the key highlights of the index treatment. Majority of the patients were treated conservatively, more than 80%, and out of them, majority of the patients were actually treated as inpatients, and the mainstay of treatment was antibiotics with or without steroids. Among the surgical cohort, only 17% of the patients had surgery done, but they had multiple options. They had lavage plus drainage, resection with anastomosis, and resection with either a covering or an end stoma. These were some of the key predictors of index treatment failure, severe comorbidity, hinges, or severe disease at presentation, and surgery. When we look at the overall management, as you can see here, majority of the patients were managed at all capture points, index, 30-day and 6 months, conservatively, and only a minority of patients had undergone surgery. Majority of the patients at the index and the 30-day were managed as emergencies. But if patients could delay their surgery somehow, and at 6 months, majority of the patients actually had a planned surgery, which did have an impact on their surgical management. When we look at the type of the surgery the patients had undergone, if you look at the index and the 30-day management capture points, majority of the patients had Hartmann's procedure, but if patients could wait and surgery was done at 6 months and beyond, a majority of them could have a resection and primary anastomosis. When we look at the anastomosis and stoma formation data, at any index presentation, majority of the patients either had an end stoma or a covering stoma. So it amounts to about more than 80% patients had one or the other kind of stomas. But at 30-day, the stoma rate formation drops. But if you look at the data at 6 months, majority of the patient did have a primary anastomosis, and a minority had a covering stoma and end stomas. This is the data when we compared the patients who had left and right-sided diverticulitis. Again, a very busy slide, but the key highlights of this table are that right-sided diverticulitis in overall across the world occurred in more than 70% of the Asian patients. Again, male and female ratio was equal. Majority of the patients, close to 80%, were non or ex-smokers. The BMI in right-sided patients was slightly lower than the left-sided patients, and most of the patients had good baseline health at index presentation. When we looked at the treatment outcomes between the right and left-sided groups at 30 days, again, these are the presentations and these are the key highlights. There was lower inpatient treatment failures for the patient with right-sided disease, lower inpatient readmissions for the patients with the right-sided disease, and lower 30-day mortality rates when we compared the right side and the left-sided cohort patients. Now, this is the summary of my, the time is very short, so I had to present the selected data. We do have much more data, and we're analyzing it, and we hopefully will be publishing it in the form of a paper. But in my opinion, one of the most important outcomes of this study was development of a network, a collaborative network across more than 30 countries, which is growing day by day. And we do have now the resources and the network to conduct many more impactful studies in future, and which I think is one of the most important outcomes of investing in this kind of studies. I would like to thank all the contributors. It's not an easy task to conduct a study across more than 30 countries, 80 centers, I want to thank and acknowledge the effort of all the contributors and the collaborators for this study. Thank you very much.
Thank you very much, Surendra. So please come and join the podium. So we have listened to the final results of 3 very important international studies: the EAGLE-2, the Latam, and also the east of Damascus. And now we'll start our panel discussion. So we have a truly international panel as well, with surgeons and experts from South America, Europe, and also Asia. So now let's start our discussion with the EAGLE-2 study first. So Lizzie, very exciting, all right, to learn about the final results of EAGLE-2. And I think it has shown that, you know, the EAGLE study, the original EAGLE study, the results are actually replicated almost, because we all see that, you know, operations performed by surgeons who have completed the training, they have a much lower anastomotic leak rate when compared with those who haven't, you know, completed the training. So very exciting. So that's exactly, you know, the message from the EAGLE study. So now, can I ask, you know, because I think on the panel, I think also, most of the surgeons actually, we have participated in EAGLE and also EAGLE-2. So do you have any comments about the final results? Any questions to Lizzie? Anyone, maybe Philippi?
Yeah, well, first of all, thank you for the invitation. I think this is a great opportunity to come together to see our results of what we do around the world. So my question would be, this is probably an extremely cost-effective method of saving lives. And I don't know where Dr. Lee is. There. So there she is. So as a professor of surgery, we deal with residents all day. Have you thought about giving this to the programs, to the residency programs, in order to prepare the people from the beginning?
Yeah, absolutely. We have engaged with a number of different societies. It's been sent out to as many residents we possibly can as well. And we hope that for trainees, it's filling in the gaps where it's the unknown unknowns, where they weren't clear that there were parts that are missing, as with every training. And every single operation we do has astronomical number of variables, decision making, and this is meant to support multiple aspects of that, almost like a black box, but support the whole process and pathway. Yeah, definitely.
Right, how about, Olivo from Brazil?
Okay. Thank you for the invitation to participate on this panel. And I would ask about, of course, the training is it's cost effective. And how do you compare the previous and the second part between the trained people?
We actually did collect data. It was a bit beyond the scope of this presentation of those who participated in EAGLE-1 and EAGLE-2 as well. And it'll be fully expressed in the paper and described. And there is definitely a change of environment, and it's difficult to capture every single variable that goes into that aspect of it. But the feedback that we got from part 1 and also part 2 is that continuing engagement as well as new engagement was always welcomed. It was received very well by surgeons, consultants, and also trainees as well as medical students. We do want to put out a survey to look at the feedback directly from all of these participants, as well as potentially patients as well, to the effect of this.
So about Malaysia, I think Malaysia is also, has actively participated in the EAGLE-2 study. So, any comments from Malaysia?
Yeah, thank you very much. Yeah, thank you very much for the invite to be in this panel discussion. Right, I think it's a very good study, and then a good way to actually ensure that we have I would say standardized way of surgery. I'm intrigued to see there is some participants that actually dropped out of completion of the online training. What was the reason for it, and what do you think we will be able to do differently to ensure that anybody that does it continue?
Yeah, it's a good question. With any training, really, or anything, there is always going to be some attrition that occurs with the participants. We try to make it as accessible as possible, that they could continue where they had left off. But sometimes it was too burdensome in especially demanding times for different residents, and also during COVID as well. We found that doctors did have more time, but also were very stressed as well, under pressure.
Okay, and from what Lizzie had presented, we all noticed that, still, 22%, all right, of operations were performed by surgeons who had not completed the training. How could we reduce this proportion, all right?
It's a good question again. Engagement is always a tricky thing to get across, and it's hearts and minds, really. The department heads and leads were very engaging, but it's difficult to achieve 100% in any environment. I think it demonstrating the good outcomes from the EAGLE study with patient-level primary data will definitely help engagement and also further support with evidence, and hopefully we'll be able to achieve much closer to 100%.
And actually this, whole training program actually reminds me of ERAS when we started, right? So it's like, at the end, so there will be evidence and then guidelines, and now everyone is practicing it, all right? ERAS, I think most units in different parts of the world, we are practicing ERAS. So do you think we can get there? I mean,
yeah, so
with the, the EGO program.
Yeah, so there's always typically that curve that we have the early adopters, and then everyone else comes in, and then the social atmosphere and social environment changes. This inevitably still takes time, but we can always reduce that time by providing good evidence, by putting this in our guidelines, by promoting this, and we can spread this with the early adopters. And already on EAGLE 2, we have been able to engage a wider community. So yeah, you're right. It is like that. There's always a journey, but hopefully we'll get
True. That's wonderful. Okay, so now let's move on to the next study, Latam, nickel. All right, 12.6% mortality overall. What do you think of it? High, low, or expected?
Real. Real. It's not, I don't think when you go to discussion and when you compare to other countries, some countries have evaluated this and do something about it, and they have a little bit less mortality in this type of procedures, maybe 7-8%, but 12% seems like not high, not low, it's real number.
A real number, correct. Now, and then you did a multivariate analysis, and then you found that age, old age, comorbidity, SOFA score, and also open surgery were predictors, all right, of mortality. But hospital volume was not a predictor.
I think that multivariate analysis sometimes plays a tricky role in interpreting the data, because then when you see the multivariate analysis, you only see things that are not modifiable, because it's an urgent procedure. You cannot pre-rehabilitate a patient for that. But there are a lot of things that have been found in the study. For example, that half of the patients that died actually only had a resident operating without a surgeon, or a patient going to the OR without a surgeon seeing the patient before going to the OR. Those things, or for example, an anastomotic leak, which is higher in patients that died. Those things we can work on to improve results, I think. I don't know.
Maybe comments from Philippi and also Olivo, from also participants of the Latam study.
Okay. Nicholas, about the diagnosis of these patients, some of them go to surgery without diagnosis. Does it interfere in this result, 12.6 mortality?
I think that this was delays, and who diagnoses or who decides who go was not a predictor in the multivariate analysis by itself. But I think we can agree that if you have 20% more of patients that died that didn't have a surgeon seeing them before, that is a very high number. And I think even if you can associate it directly in a multivariate analysis, it's something that plays a role. I don't know if you think.
Thank you. We had the chance to participate. So there is a difference in the number of patients recruited per country. Did you find any difference? They are low numbers probably if you disaggregate them, but did you find any difference between countries or regions or public versus private hospitals or something like that?
I think even though that information, I think it would be, we cannot agree, it would be relevant. We always try not to do a differential analysis between countries or between centers. Yes, to take low and high volume because it's something that is important, but not between countries, because when you include a difference in countries and then it seems like you might be wanting to expose something, I think it doesn't really help. Therefore, we usually don't do differential analysis between countries.
Maybe not between countries, but private or public hospitals, we have a huge problem because we have shown in Chile that the difference in survival in oncological diseases, it's a striking difference between public and private hospitals. I don't know if you saw something like that here?
We did include the difference between public and private, and we didn't find differences between the groups.
All right. Can we listen to the view from Asians? Because since we've got two, panel members here from Malaysia and Singapore. So do we have a similar observation in Asia regarding the results of the Latam study?
Yeah, I think the good study actually that was done, the Latam, I think from Malaysia where we come from, actually Malaysia comprises of two different areas, which is East and West Malaysia. So definitely there be difference in the diversity of surgeons as well as access to healthcare. So I'm very intrigued to actually see whether we could actually apply this formula to see whether there are things that we can identify. Things that you identify is like the lack of resources and junior surgeons operating. I think we have the same problem as well in Malaysia. And I think if we have this sort of audit or studies that look at it, we can identify and then maybe we can work to actually rectify it. I think that it's something that's very positive that we like to actually see as well. But yeah, same problem. Emergency surgery always done by junior at early or odd hours in the morning. That's
always junior. All right.
Usually.
How about Singapore? Enough supervision during emergency surgery?
Well, Singapore is a bit lucky and fortunate. We have a more structured training programs, and even the exit criteria to become a specialist are a bit more harder. So the training overall is more standardized. So we usually don't have the issue either of the resources of the training of the manpower. So I would say we are a bit lucky, small, and a bit more fortunate.
Right. How about Lizzie? Europe? UK? Yeah. Any comments about the Latam study? I mean,
again, the interesting aspect was the patients could take into theatre without a preoperative CT. But perhaps this is the environment that's there. Is it that it's inaccessible? Do we know? It's real world.
I think when it comes to urgent procedures, I think the protocols fail, right? It's 2 a.m., no one's there. So we do whatever we can with what we have. I think that now that we have the data in hand, maybe one solution would be to try to find some way of protocolizing how the patient gets to the hospital, how the patient get to the OR, which information it's like a legal study. You make a checklist, things that need to happen before the patient comes to the OR. Yeah.
Sometimes the study can make like a recommendation for the futures, let's say, analysis, and see if we're going to have the staff there, we're going to have the CT before and everything.
Right. So final question to Nico. Do you think it's worthwhile to pursue to make Latam bigger and roll it out to be a global study?
I think that I showed that in the last years we have all been working a lot trying to create high quality information to know what's happening, and I think because of the effort everyone has done, now we have a lot of information. The problem is we are in a turn point in which, with the information, either you make decisions to try to change and improve, that could be one thing, or the other thing is continue doing the same, and it's fine, because actually that could be another way.
All right, so thank you. So I think we need to move on to the final discussion for the final study, east of Damascus, right? So Surendra, congratulations on the completion of the study. So we're trying to compare right versus left-sided diverticulitis. And we found, what we found was that in the right-sided diverticulitis, patients usually younger, with lower BMI, with less comorbidity, and also their treatment outcome was better when compared with the left-sided diverticulitis. So my question to you is actually, an ESCP actually there's a guideline for the management of diverticulitis, but obviously we've shown that right and left, they're different. Do you think we need to have a separate guideline for Asia, even for South America? Because I think we all see that in the east of Damascus studies, we do also have patients from South America, although it's more proportion, but we know that, South America, they have also more left-sided, and also the patients actually are less severe, all right? So it's slightly different from Europe. So with that, do you think we need to have a separate guideline?
Yeah, I think that's a great question. We know that 2/3 of the population lives in Asia, and we still follow the Western guidelines. And we have shown that right and left-sided diverticulitis behaves differently. And what we are trying to do, we are trying to apply the guidelines which are drafted for left-sided, we are trying to apply it for right-sided. And this is high time. We have seen now this data east of Damascus and other studies have shown that we need to change. We need to take note of this data from the Asian countries or in the South American countries and maybe relook at the guidelines. So in fact, earlier in the morning, I had a discussion with one of the American surgeons. He said, I even don't know how to manage right-sided diverticulitis. I've never seen, but I'm on the panel of drafting guidelines for the ASCRS. So which is unfortunate and funny also. So I think this is high time that we collaborate with each other. We take note of each other's data and outcomes and come up with a combined or at least guidelines which are appropriate for the appropriate clinical condition. Yeah.
Right. So comments from Malaysia? Yep, Your Worship.
Yeah, I think I mirror Surendra's idea. I think we have lots of right-sided diverticulitis in Malaysia as well, and I agree with him saying that we are following the international guidelines. And I will think that we can use this platform today if you can actually focus our similar studies, looking at regional and see whether we could get something out of it and whether we can, move forward and perhaps have slightly specific guidelines for our part of the region, perhaps.
Yeah, thank you. So can I have the opinion from, South American colleagues? Because, in the east of Damascus studies, I think there are less than 70 patients included, but, we do see that, well, according to east of Damascus in South America, you've also got more left-sided diseases and also less severe. Is that the real case, in South America from your clinical practice?
So in Chile, we rarely see right-sided diverticulitis.
Rarely see right-sided.
Especially the ones that might need surgery, emergency surgery.
Right. So
mostly are left-sided.
Left-sided. How about severity?
If I can ask a question.
Sure.
You mentioned this high rate of Hartmann's procedures, obviously, in the emergency setting, right? Do you know how much is the rate of the reversal of the stoma? Because in Chile, we have a huge number of patients that will never get the stoma reversed, and they will live with the stoma forever because of lack of resources.
Unfortunately, I don't have data on that because we didn't capture it on reversal of. But again, these are some of the interesting questions, how much burden of a stoma we give to our patients and how we need to change practice. And with this collaborative network, there's an opportunity to seek answers for all these questions. They are very important questions. And now we have an opportunity to possibly explore how we can answer them. Yeah.
All right, maybe a final question to Surendra. Yeah. Now, we've completed the East of Damascus study. So what do you think will be the next step?
One of my introductory slides shows that we want to possibly explore whether we can do an interventional studies in future. East of Damascus is just an audit of treatment and outcomes. There was no intervention in this. But we also learned lessons that it is not easy to conduct studies across the globe because there are different cultural and ethical and approvals required. But this is an opportunity to see whether we can conduct interventional studies in future.
All right, so with that, I think I will wrap up this.
Sorry, can I add one more comment? Okay. In fact, what I realized for right-sided diverticulitis, even we don't have the right definitions. If you look at the literature, every paper has different definitions of what is right-sided diverticulosis, what is diverticulitis, what is complicated, non-complicated. I think the next step at least will be to standardize the definitions, which is lacking for left-sided diverticulitis also. So we can combine and look at how we can define this disease correctly and then move on with the new research.
Indeed. So thank you very much. With that, I think I will conclude the first session of the Global Reach Symposium. So I would like to thank the three speakers. Wonderful presentation. Also my three panel members. Thank you very much. So I hand over the time to my co-chair, Dion, all right, to moderate the next session of the Global Reach Symposium. Thank you.
So I've heard from three truly global studies that are completed and fully analysed. And I think that the panel there have made three really important suggestions. So in EAGLE, they suggested that we should look at disseminating the training modules to residents. And I think that that is a really good idea, and we could work with our colleagues in the Global Reach Committee to do that. East of Damascus, we need to have context-specific guidelines. There's no doubt about that. And in the LATAM study, the panel just suggested that we should look at guidance and standardizing pathways of care in that emergency setting to try and prevent surgeons going to theatre without a diagnosis and try and improve our outcomes. I think really three very important suggestions. We're now going to talk about three new studies that aren't fully analysed. I'd like to invite the panel to the stage, please. The first panelist is Julio Moreira Jr., who is the past president of the Brazilian Society of Coloproctology. Julio, welcome. Could I also invite Christian Ferrufino, the president from Bolivia. Christian, welcome. And could I also invite Samar Hamoud, the president from the newly formed Saudi Society of Coloproctology. Welcome, Samar. And by no means least, Mark Paul Lopez, the president from Philippines. Mark, welcome. So the first of the new studies that we're going to talk about is a global study, and we're going to hear about Alligator from Teddy Aniomi. Teddy, welcome.
Hello, everyone. It is a pleasure to share some early results from Alligator study. Thank you, Prof. Morton and the Global Reach Committee for the kind invitation. I'm Theophilus Teddy Kojanyomi, a surgical registrar in the East of England INRI, and a clinical PhD fellow with the University of Birmingham Global Surgery Unit. I would like to acknowledge Dr. Nepogodiev and Prof. Bangu for their guidance and support in this study. So Alligator is the appendicitis global outcome study, which is aimed at identifying key system-level gaps in the emergency care pathway globally and how these can inform strategies for whole system strengthening, using appendicitis as a tracer condition. I have no conflicts of interest to declare. What I'm going to share is not published, and data upload is still ongoing in the final stages. So I'll kindly ask that we do not share on social media. So Alligator was a prospective cohort study open to any hospital worldwide performing emergency appendectomy. We included all patients undergoing appendectomy for acute appendicitis. Any other indication was ineligible. Because no single outcome measure can fully describe the quality of emergency care globally, the steering group defined 8 key performance measures spanning delay, presentation, diagnostic, management, and outcomes to define and evaluate surgical care systems. So participating teams contributed data on all consecutive eligible patients during 8 predefined 2-week windows. So we've seen remarkable global engagement with about 45,000 patients recruited from 1,300 hospitals across 112 countries. Now, this level of participation allows us to make truly global comparisons across a wide range of health systems, income settings, and care modules. We've had very good spread among income groups. This includes more than 11,000 patients from LMICs and low-income countries, a major strength in terms of equity and generalizability. So the data so far shows that preoperative CT scan varied widely across income groups, with much lower use in low and low-middle income countries. Now, where CT or preoperative CT was done, it was associated with significantly lower rates of negative appendectomy. Now, minimally invasive surgery followed similar patterns with stark disparities across income settings. So over 95% of patients in high-income countries had laparoscopic procedure, as compared to less than 10% in low-income settings. Now, this is a key finding. Perforation rates increased sharply with longer delays from symptom onset to surgical team review. Now, this reinforces the idea that appendicitis behaves as a time-dependent condition, where delays translate directly to harm. Patients with perforated appendicitis were 5 times more likely to experience major complications compared to those with non-perforated disease. So what are our key takeaways here? Perforation is time-dependent and increases complication risks. Access to CT and minimally invasive surgery is far from equitable, with high-income countries dominating. Preoperative CT reduces the risk of negative surgery. Now, we propose a global standard, review by a surgical team within 24 hours of symptom onset, followed by a timely, definitive treatment. Finally, before I take my seat, I want to acknowledge the people who made this study possible. A massive thank you to our operations team for their relentless support with the day-to-day running of the study, to our 7 regional leads and the 164 national leads, who each played a critical role in delivering the study in their countries and their regions. And then to the 2,230 consultant leads and co-leads who have made this study possible in their various sites. And finally, to the 16,000 plus collaborators, I want to say thank you very much. This is your achievement. This has truly been a global team effort, and I'm incredibly grateful to be a part of it. Thank you very much. Before I sit down, I want to say we have a new study that's upcoming, the Search Pass study, the cohort COVID Search study, and I would like you all to keep an eye out for it. Thank you very much.
Fantastic. Great start. And now we're going to talk about an open study. And the open study is Wolverine. And we've got Professor Gabriel van Ramshorst is going to talk to us about this. And so if this is a study that you can still participate in, if you wish to. Gabriel, welcome.
Thank you very much for that kind introduction, Dion. And thank you for the Global Reach group to have us here in this symposium. So this study is supported by Ethicon. And we know that there's a high variability in the surgeons' methods, the way they close their wounds and the way they want to prevent surgical site infections. And it's different even in the same department. Short-term abdominal wound failure does seem to impact long-term abdominal wound failure, and by that I mean incisional hernia. And for short-term abdominal wound failure, you could think of surgical site infections, surgical site occurrences, and abdominal wound dehiscence. There is, however, a knowledge gap in literature because we don't really know what the impact is on a patient, especially in this time frame after discharge. You usually see the patient once in the acute moment and up to 12 months post-operatively. So change does not come from one study usually. So you need to have engagement of groups of surgeons, of registrars, throughout their training and their clinical practice in order to make people change their clinical practice. So we had a first audit phase, and the audit phase, pictured in blue, collected clinician-derived clinical data. Usually IB permission was not necessary, and we looked at short-term clinician-reported 30-day outcomes, and that study took place over a time frame of 6 weeks in late 2023. What we are trying to launch as soon as possible is the cohort study. And for this, we will collect the patient-reported outcomes. And we're building this on the experience that the University of Birmingham has built using patient accessible apps to get that vital information directly from the patient and thereby reducing clinician burden. So there is an IB permission required in most countries, and in the UK it has been granted, but we're still ongoing with pending approval of an amendment that we need. And we will measure, as I said, between 30 days to 1 year. And the audit, I must say, just to sketch a little bit what we found, we looked at early abdominal wound failure, and this was actually a new composite score of SSI and SSOs and abdominal wound dehiscence. And for the late ones, we will also look at incisional hernia. And we asked clinicians to report the data on their wound closure techniques. What suture did you use? What technique did you use? How did you disinfect the wound, etc., etc. We were able to include 1,971 patients in this time frame of 6 weeks from 104 hospitals from 40 countries across 4 continents. And what's really helpful is that this was a way to collect emergency operations surgery data, which is noticeably difficult to get by, and especially the short-term outcomes. I want to sketch just a few of the significant factors that we found, and some of them are not surprising. For instance, the body mass index over 35. We also found increased frailty scores, which I think is good because it also lays a pathway for future studies that we can develop with interventions. What's surprising to some, not to me, I must admit, is that the large bites were a risk factor for early abdominal wound failure, with an odds ratio of 1.72, which implies that by taking the small bites technique, which was published in The Lancet in 2015, you could reduce your patient's early abdominal wound failure. And of course, not surprisingly, the contamination degree would heighten the odds ratio for early abdominal wound failure. So the main finding, I would say, from this paper is not only that the small bites protect against early abdominal wound failure, but we also found that 22%, so that's more than 1 in 5 of our patients, still have unhealed abdominal wounds at day 30. And the impact of this on the patient, that's really an interest of ours. So for the cohort study, as I said, that we're launching, the study objectives would be to link this early abdominal wound failure with the long-term abdominal wound failure and focus on the quality of life that the patients have and the issues with healing and incisional hernia. But we will look for the clinician-reported data on the same data as we collected in the audit, focusing on the techniques for the wound closure and surgical site infection prevention. So this again will be an international perspective cohort study. Of course, it will be multi-center. We want to collect as many patient data as possible because we're very aware that not all patients, may be able to complete that 1-year follow-up. We'd like to have as much data as we can. So there will be no interventions from our side, and we will need patient-level consent for the patient-reported outcomes. So we'll focus again on adult patients undergoing general or colorectal surgical procedures. So this would, for instance, exclude a patient undergoing cholecystectomy or Whipple surgery, for instance. It can be elective or emergency surgery. We're especially interested in the last group. And the minimum incision that you should use would be 5 centimeters, but that can also include extraction sites for minimally invasive surgery. We're not looking at patients who already have a profile of developing or having developed hernias. So if they're undergoing a hernia repair, these patients should be excluded. And we'd like to keep the group a little bit homogeneous and exclude patients who are undergoing HIPEC surgery. If patients are having a local stoma reversal, they won't be eligible either. And we do need to have this patient to complete these questionnaires, so we need to have a method to reach these patients. So I will not talk you through the assessment schedule. This is just hopefully a cheerful message that the clinicians don't need to collect anything after day 30, but the patients will report various questionnaires that have mostly already been translated in local languages. We are operating on a single corporate authorship, and every site, even if you did not participate in the audit part of the study, can include up to 5 collaborators. So they will be co-authors, but we need to have at least 10 consecutive patients and at least 95% data completeness. And this was actually taken from the COVID studies, and we had a 98% data completeness in the audit part. The national leads are really important, and I cannot stress the importance of having someone like James Keatley, Laura McGill, statisticians from Birmingham, and also Mohammed Al-Hadi, who's been very instrumental in preparing the manuscript for the audit study. As you can see, this is far from 195 countries or 193 countries that we currently have. So we're really welcoming new national leads, and we'll try to explain as much as we can about that in the near future. So these are the contact details of the study. You can follow the QR code, and I'm looking forward to launching the study soon. Thank you for your attention.
Thank you, Gabrielle. Do join us. So that study is open. Sites can join. Please do contact us if you're interested. Last but by no means least, we're going to hear some early results from another study that's open, another study that you can participate in. And this study is Profer. And it's a great pleasure to welcome Sue Blackwell to give the talk. Welcome, Sue.
Thank you very much, Dion, and thank you to the Global Reach Committee for inviting us to present today. Those of you with long memories will remember that we first launched the idea of Profer in 2019. I can't remember what conference that was, Vienna.
I can't remember dates at my age.
No, neither can I. In 2019 in Vienna, and then COVID happened. And also, we wanted to use novel technology to collect patient-reported outcome measures, and we went through 4 different app companies before we settled on a slightly easier version. So just to recap of what Profer is, it's a prospective multi-center cohort study. As with Wolverine, which has followed the data collection for Profer, the clinician element of it ends at day 30. If the patient has surgery, if the patient doesn't have surgery, then all the clinician has to do is enter baseline data. Everything else, all the other outcomes are coming direct from the patient via REDCap. And as with Wolverine, that's going to be done either mobile phone or by email, so patients do need to have access to that. But with Profer, what we want to do is to audit peristomal hernia treatment across the world, to look at the overall patient-reported quality of life outcomes, and then also to explore whether there's any associations between what's done in theatre and patient quality of life and patient outcomes from hernia repair specifically. So who can take part in Profer as a patient? Well, any patient who has a symptomatic peristomal hernia. So they don't need to have had CTs done. If they have a peristomal hernia or a suspected one, and the patient is going to see their stoma nurse or their surgeon because they have symptoms, and they are eligible. They do need to be over 18. They need a life expectancy of more than 12 months because the follow-up is currently 12 months. And they need to have a bowel stoma. If they have an isolated urostomy, then they're not eligible to take part because urostomies are quite different. And also, if they're having surgery, they need to have a stoma when they come out of theatre. So if you are reversing the stoma and restoring gut continuity, then obviously they don't have a peristomal hernia, they can't take part. And we're looking for patients who are having conservative management and also who are having operative intervention, because we want to see, is there a difference between the two cohorts of patients? And also then we can look at the crossover rates between conservative management and operative intervention. So Profer had a pilot phase. We wanted to test using the patient-reported outcomes via REDCap and to make sure that everything worked before we rolled it out wider. So the pilot phase was UK only, and it was funded by Bioresearch UK in the UK. The first site was the QE at Birmingham under Prof Pinkney, and it opened in August 2023, and you can read the protocol, which has been published in Cody. And to date, we've got 28 sites opened and 335 patients consented. I should say a lot more patients have been screened, but obviously not everybody's eligible, and of those that are eligible, not all of them have consented, because the one thing we have found is that patients say, yes, I want to take part, but because they're consenting themselves away from the clinic room, some of them don't always follow through and do that. They want to do it, but for whatever reasons, they then don't take part. So just a few bits. I haven't got much data on it yet because we haven't really done an analysis, but this is just the headlines. So of the patients that have consented so far, you can see the majority have a colostomy, ileostomy, there's a few others, and there's some where the data isn't there. We'll have to get it checked, but for some of them, because patients go from one hospital to another and their notes don't necessarily come over, and people are just looking through the notes and can't find it. So the reasons for the index stoma surgery, obviously, 31% cancer, 24% IBD, and then the other benign was like 29%. And then there was a small percentage of patients who are trauma or ischemia, and then again, there's some unknown. But one of the things we're doing in Profer is we're using Measure Yourself Medical Outcomes Profile, where the patient selects the symptoms and the activities that are impacted by their hernia that they want to be fixed by having their treatment. And that's really quite interesting because it's what the patient wants from their treatment in their own words. And I'm doing my PhD on peristomal hernia, and the data from the pilot phase, the MIMOP data, I've done an analysis of that, and that is it's in the posters, so you can go and have a look. But that, when you look at that, the biggest symptom that patients are reporting is pain and discomfort, which is actually not mentioned very much in the literature that's available, the patient-facing literature that's available. And also the second most highest was like stoma-related symptoms, so leakage and then sore skin and things like that. And I think that's really important that we've got that data, because I think it shows that perhaps when patients are looking to have surgery, that they might not, those symptoms may not be fixed by having their peristomal hernia fixed. So the next steps, obviously, this is global reach. We want to go international. We are ready to open this internationally. We need to do the translation of the patient-facing CRFs. So we have them in Turkish. They're on REDCap. We're in the process of Spanish and Italian, and what we're doing is giving people the access to REDCap so they can do the translations direct. So if you want to be a national lead or help with the translations, please email us. We're also on Twitter. If you help us do that, then obviously you will be listed as a collaborator, and if you scan the QR code, that gives you the form if you're interested in taking part. But please do, because as clinicians, it is not that burdensome. So it would be really great if we could get as many patients across the world entered. So thank you very much, and I hope we do take part.
Thank you so much, Sue. Just to say, questions from the floor, you can either put them in online and we'll read them out, or if you want to go to one of the mics, please do. We'll be happy to introduce your questions. So we've got 15 minutes now just to chat through these studies. I think, Teddy, that's so exciting. What a huge response you've had from across the world. I suppose the one thing I would pull out, it kind of comes from the LATAM study as well, is are there issues around pathways? Are you seeing huge variation in pathways of care into getting your appendicitis treated? Are there improvements that we could make there?
Definitely. There's significant variability, especially when it comes to diagnostics and the approach or surgical management of these patients. When it comes to diagnostics, for instance, CT scan, as you can see, was way low in LMICs, and then LICs. Now, the opportunity I see here is if we are to increase diagnostic ability of these low-resource centers, this cuts across horizontally, would affect every other specialty, including surgery as well. So that's a good opportunity there.
So I think there's a lot about that in surgery anyway, because surgery is a cross-cutting theme. So if you improve the infrastructure around surgery, you improve the whole system. And I think that's a really clever point. I was going to just come to Mark in the Philippines. Mark, does this study resonate? Do you think this is an important study for you?
Yeah, well, again, thank you for the invitation, and thank you, Simon, for being becoming part of the community. I was looking at the LMICs, the data on the LMICs, and yeah, for something so commonplace, appendicitis and appendectomy, there's so much to talk about when you public health, resource allocation, and even training. It does resonate for us because many of the targets weren't met by the LMICs. Very particular about the CT scan, the use of imaging. We're down at 18%, and the rest of the world is high up there. Also about the number of the laparoscopic penetrance rate, it's pretty low for the LMICs. I'm not very sure about the reason for this that was cited, if it were cited by the contributors. But when it comes to the imaging, I'd be interested to find out if among those with a negative appendectomy, how many of them actually had a scan and how many didn't have a scan, because for all intents and purposes, what we try to impart on our trainees is that the diagnosis of appendicitis is still largely clinical. This does have impact to us because it comes at a cost. We cannot have every patient who comes in through the emergency department undergo a CT scan, or even a good part of them undergo a CT scan, because that's going to push back other patients who may need the scan more. So I'm not sure if you were able to look into that. Thank you.
Samar, in Saudi, I assume that there are very good resources, good facilities. Do you think the pathway is well standardized in Saudi?
Yeah, I think so. First of all, thank you, Dion, as well as Simon, for including our Saudi society. We look forward for our future collaboration. Yes, we do. Most of our centers have the facilities and, the guidelines as well as the practice is almost, straightforward. What is of interesting that I would like to ask, as he highlighted, the perforation after 72 hours is where you have complication. Do we know what was the reasons of this delay? Is it because we don't have CT, or is it, is it a clinical judgment? Because I think this is a key issue to improve the outcomes.
Okay, thank you very much. We did not specifically ask for reasons why there were delays, but what we did ask for to look at the pathway properly was how many centers did they visit before they got to the operating center. And you can see from the preliminary data that those who visited multiple centers before coming to the operating site had increased chances of perforation. So I guess if there is a streamlined pathway, then of course that would minimize some delays.
So Surendra, did you want to come in?
Yeah, I mean, I want to make a comment with respect to doing CT. We know that one of the important differentials in Asia for appendicitis is right-sided diverticulitis. They are in the same age group. They present more or less similar, and we have seen that when we routinely do CT scan, we can avoid appendectomy or negative appendectomy in 10 to 15% of patients, because it turns out to be diverticulitis, and we know majority of them can be managed conservatively. But again, it's not easy if resources are limited. My question is, did you notice any difference in the outcomes in the patient between who had CT scan and who did not have CT scan?
No, we've not looked at that yet.
Okay, I think that will be something very interesting to look at.
Samar?
Also, as you know, appendicitis is most of the time is diagnosed and seen in the ER by junior trainee. So I think it's very important to know if the delay, were they ever seen by a specialist, or because we take things for granted. It's always seen and diagnosed, and then they can tell the on-call staff. I think it's very important to have a look at
the data from South America is quite clear that people are often not seeing the right person at the right time. And that is probably a fixable problem. So I think you'll hit the nail on the head. Teddy, at the end there, you were just highlighting, what a fantastic piece of work, by the way, but you've highlighted your plans for next year. Did you want to mention about future studies?
Oh yes, we do have a couple of studies that are coming up. We have the Surge Week study. We're hoping to launch later this month. And then also we have the Surge Pass study, which is looking at lowering mortality after surgery in low middle income countries. This will be a pilot cluster randomized trial. So please do look out for that.
Excellent. So if we could move on to Wolverine. Great work, Gabrielle. I mean, it's very exciting now. You're moving into the cohort phase. Just going back, you've used a composite endpoint. I must say I found that really good, but do you have any concerns around that, or are you really happy with that composite endpoint?
Well, thank you for that remark, Dion. Well, I guess an alternative would have been a textbook outcome, because that would have been a healed wound. But we did not think that there would be so many people who would have unhealed wounds by day 30. Just imagine like the burden on our healthcare system and on our patients. We're having 22% of your patients with open wounds at that time. And how long it will take for some people to actually heal their wounds. I think it's a massive burden, and we need to try something to fix it.
And I just would like everyone to understand that you're now in a position to correlate early wound problems with late wound failure. That is incisional hernias. And that's what this study is really going to identify, the link up between those two. I think that's quite exciting, is it not?
Well, it is very exciting, but what I'm most excited about is that there's so many people who, within this time frame of the study, participated with a very highly motivated team, and to have so many countries, so many national leads dedicating their time and sacrificing all other things that are important in life to help us to progress with this and build a great data set. And hopefully, that's at least what I'm working towards. It would be great if we could eventually have some interventional study where we can identify the patients who would benefit most. And at the same time, whilst these studies are ongoing from like the survey back in 21, with the audit now and the cohort upcoming, it means we can have an entire generation or several generations of up-and-coming colorectal surgeons being very cognizant, very aware to what extent it will mean for the patient if they execute the abdominal wound closure and surgical site perfection intervention strategies up to a high level.
Absolutely. So Helio, in Brazil, abdominal wound failure, incisional hernias, is this an area that we could be helping in, that having information about what people are doing could be useful?
I think it could be useful as well, especially in emergency units. It's quite common to have laparotomies. And I didn't see in details all the things that you're collecting. I would think that you had compared different incisions, like midline incisions, pararectal incisions, suprapubic incisions, to see if you have differences on that. But I think it's quite a good idea, and we could standardize this wound closure in a better fashion.
And in Saudi Arabia, Samar, is open surgery still commonly performed, or is everything done through minimal access now?
No, everything is almost is done through minimal and robotic. Maybe one of the things is that we have high rate of diabetes. in Saudi Arabia, hence maybe the infection is higher, and maybe, yes, that will affect the wound healing. The other thing is I wanted to ask the definition of SSI. Is the colorectal wounds are clean contaminated or contaminated? Because this is also always a debate between us and the infection control. Do you consider them, well, I think they are all contaminated, so this is something to debate.
No, well, the official CDC classification talks about, well, not objective amount of spillage. So I guess you could reason both ways. You said there was no spillage of significance, and then you'd have your clean contaminated.
The other thing, even for laparoscopic or robotic surgery, we end up doing incisions to extract the specimen. And as you said, it's 5 centimeters, so we can use even these patients to see. There are a few papers showing that if you do midline incisions rather than suprapubic incisions to retrieve, like right colectomies, there's a higher incidence of hernias in the midline incisions. So I think that even for minimal invasive surgery, you can use patients.
If you have an extraction site, then I think it becomes very important. So I absolutely agree, and thank you for flagging that up. Mark, your thoughts? Do you think there could be, we could use this data to inform surgeons about better technique, about better wound closure? Do you think that would be valuable to surgeons in the Philippines?
Most definitely. Compared to my companions here on stage, most of the colorectal surgeries are still done open in my country, except perhaps for those with a established colorectal surgery training program. Given that, from among the risk factors cited in the first part of the study, high BMI, et cetera, what is very telling and maybe different in my country is that there's a higher rate of undernutrition, which may be contributory to the post-operative problems with the wound, which of course is a big burden for LMICs.
Great, so we'll look forward to participating in the second cohort study for Wolverine.
You're right.
Excellent.
I think, Dion, if I may, moving forward, could there be a possibility of coming up with a training module similar to
Yes,
so
this data can be used to build educational packages that we can put out. And as you've raised that point, we've got a question from the floor. Henry Dawson has just asked whether the Eagle 2 results are explained simply by the emergency elective split. We have analysed that, Henry. No, it's not. It is not simply emergency elective split. That difference is still seen if you take the emergency patients out. The other question was raised is can people access the Eagle training platform? And the answer is it is freely available, and it is on the ESCP website, and you can click on and do the training modules whenever you want, and they're open to everyone. So, Sue, moving on to Profer, a very exciting time. You've just rolled it out in the UK. Presumably you've kind of piloted the app now. Are you happy with things? Any learning from this? Any sad moments, or are they all happy moments?
They're all happy moments. Well, they are now that we're not using an app. So I think that was probably our stumbling block, and leaving COVID aside, I think that was one of the reasons it took so long to get going, because we wanted to use an app. I know it was like, 2020, we're using novel technology, it's an app. It's not really that novel anymore, is it? But in the world of surgical research, it is.
It is, yeah.
And yeah, it was a bit of a nightmare, and as we said, we went through 4 different companies, and it was very painful and very frustrating. And I didn't have grey hair when we launched Profer in 2019.
But actually, the technology's moved on. It's easier now. The red cap system's inclusive, so it's really going well. Surendra, do you think, because this is a much more specialized thing now, parastomal hernia management, is that something that surely in Singapore the surgeons would like to engage with, isn't it?
Yes, of course. I mean, there's a saying, once a patient has a stoma, he or she will develop a hernia. So any patient who has a stoma is at risk of developing a hernia. My question to Sue is that what do you think will be the major learnings of your study which can help in improving patients' either outcomes or quality of life? What do you think will be the major learnings from this study?
Well, I think for helping to improve patients' outcomes and quality of life, I think we're going to have the data on how their quality of life is after their treatment, and I think that's going to be important, because we could maybe, I don't know, I'm just hypothesizing that you could look at it and see, I think people expect that their quality of life gets better after they have especially surgical repair, and I know from personal experience that that isn't always the case. So I think having, you know, data on a big cohort of patients will help us, help counsel patients better.
Yeah, I think it's still good to understand how a patient feels or thinks about a parastomal hernia and understand the quality of. Do you think you want to include some quality of life scores in this?
I can't hear very well. Quality of life scores. Yeah. Well, we were going to use SF12, so we're going to use EQ5D, because SF12 apparently is very expensive. Who knew? So we're going to have that, and obviously the MIME-UP, and we're using the colostomy impact score, but a slightly modified version, so we're calling it the stoma impact score. So we're going to get that, quality of life, actual data, as well as the MIME-UP, which is very patient-specific.
For time, I'm going to interrupt here. Helio, I know you're very excited about Profer in Brazil, and I think the Brazilian society maybe will be in a good position to support this study. Is that true?
Yes, that's true. I think it's a major problem we have to face. We still have to face, especially because populations get obese. That's a major challenge. Just 2 points I want to mention. I don't know if you had on your protocol. Those obese patients with permanent stoma, many doctors in Brazil, they already put a mesh when they construct the stoma. So if you consider to include these patients on your study, so that's a good point. The other thing is what he said. I had just had a patient that she had a peristomal hernia. We repaired the hernia, but she doesn't have the symmetry back. And she was not happy, although we fixed the hernia. So that would be a nice study to see the quality of life of these patients if they are happy.
And we're collecting data on non-surgical as well as surgical patients. I think that's really important. And I think this will create a really valuable data set to improve our understanding of the problems from peristomal hernias.
And the last thing, are you going to include stoma prolapse on the analysis as well with the peristomal hernia? No? No. Okay.
Okay, I'm going to call this to a close, but it's been fantastic. Surendra, Mark, Samar, Helio, thank you so much for joining the panel today. Thank you to all the speakers. I would just like to point out, if you want to take part in any of these studies or you want to know more about them, James is the coordinator for ESCP, and you can contact us. We want to engage as many people as possible. Please go back to your colleagues and friends and see what they would like, if they would like to take part in these studies. It's been a great pleasure with Simon to coordinate the Global Reach community. It's been a very exciting venture and one that is becoming very successful, thanks to the engagement from all of those societies. Thank you all. Sorry it's so late. Have a nice evening. All done.